Hi everyone, thanks for joining us today. My name's Emily Scahill. I'm the Manager of Peer Advocacy Supports and Services at Mental Health America's National Office. Welcome to our webinar on measuring the impact of peer support services. Our presenters today are Patrick Hendry and Kelly Davis from Mental Health America. Patrick Hendry is MHA's Vice President of Peer Advocacy Supports and Services. He has worked as a mental health advocate for the past 24 years. His areas of expertise include peer-provided services, self-directed care, organizational development, and management and sustainability. He is the former executive director of the Florida Peer Network and has assisted in the development of numerous peer-run programs and organizations. Patrick is a strong supporter of the inclusion of mental health consumers in all aspects of the behavioral health system. Kelly Davis is the Director of Peer Advocacy Supports and Services at MHA and works to promote the expansion of peer support throughout healthcare. She also leads MHA's Collegiate Mental Health Innovation Council, which is dedicated to highlighting and expanding student-led programs that fill gaps in traditional services and supports on campus. Kelly is passionate about empowerment, civil rights, positive psychology, peer support, and trauma-informed care. In 2019, Kelly was awarded the Disruptive Innovator Award by the International Association of Peer Supporters, an award given to a young person changing mental health through positive disruption. Some logistics before we get started. At the top of your screen in the gray Start Meeting box, there's a chat bubble, and you can click on that to open up a messaging window. And feel free to drop any questions in there, and we'll go through Q&A style at the end. And we're also recording this webinar, and I will send out the recording along with the slides afterwards. So with that, I will turn it over to Patrick to get us started.
Thanks, Emily. I think we're going to have a very interesting discussion today as soon as I get control.
You should have it now.
I don't.
All right, let's try one more time. All right, try now.
Nope.
All right, I can just switch slides for you.
Okay, switch slides. As I said, I think this is going to be a really interesting discussion because more than talking about how peer support measures up, we're actually going to talk about the ways that we measure the effectiveness of peer support. So kind of from an overview, we're going to look at the traditional measurements and marks of success that we use in peer support services and how peer support shifts the focus on measurement to different areas than were traditionally measured, new ways to measure the impact of peer support, and then the broader effects of peer support and peers in behavioral health. Next slide, please. So we know that peer support and peers in general impact the behavioral health system across the board, really. But some of the ways that the system likes to look at it is that we have reduced costs. Yes, we do. We have happier providers, but we also, primarily what we're most interested in is we have happier and healthier people who receive peer support services. And we also have improved outcomes for people. Next slide, please. So if you look at it in the traditional way, you're going to look at cost savings analysis. You're going to say, for this amount of money, we got these outcomes that traditionally would have cost us this amount of money, and then be able to show a savings. And in pilot programs that we've done around the country and other programs done by managed care, we have seen substantial savings when peer support is used well and sufficiently to actually affect people's outcomes. We look at some of the traditional measures, and of course, from the medical model, people are looking at symptoms. They're looking at medication management, or whether people take their medications or don't, if they're effective or not. And then we look at intensive service use, so that might be crisis stays, but it can also be emergency rooms. It can even be respite facilities, which is a step down from crisis, but it's still intensive service that peer support can actually move the measure on. Next slide, please. So some of the traditional things that the system uses to look at all types of services are the HEDIS measures, which are healthcare effectiveness data and information sets, so very dry. It's mostly used, it's the most commonly used quality measurement, and it's designed to let consumers compare plans in healthcare. So it was originally developed more for people who are looking at healthcare plans that they might be able to buy into commercial plans and be able to analyze which ones gave them the most benefit. Then we also use the Medicaid kind of core set of measures, and that's really very variable because it's left up to the states, so it's voluntary. It looks at performance for adults and for children. Next slide, please. So basically, what do? Well, they look at the PHQ-9, which is a measurement used for depression, and it looks at not only depression but also suicide ideation. And it looks at, you look at it when a person is first admitted into a crisis stay, and then you look at it as they're nearing time for discharge, and then hopefully after discharge. And the idea, of course, is to get a better score, which shows a reduction in depression and anxiety and suicidal ideation. You look at medication adherence, are people taking their medications if they choose to? Or are they saying they're going to and then they don't? One of the measures is that people upon discharge have to have an appointment within 7 days. And so we're looking to see if people actually make those appointments, if they show up for those appointments. They have to have another appointment within 30 days. And then they also are screened for substance use. Next slide, please.
It's stuck on my end now, too. Hold on a sec. There we go.
Okay. So we're not doing a very good job of seeing what peer support can do, and we're really not doing the greatest job in provision of services. These scores on the side, and we won't go into the detail of them, but it shows that really about 50% of people benefit from the services that they're getting in multiple ways of looking at it. We're looking in society, it increases in emergency department usage. Suicide rates are up. Opioid overdoses are up. People are not staying engaged in services. So once we are able to engage somebody when they're generally, first brought into the system, often in a crisis state, do they continue on and receive services? And we're seeing that people don't. Again, we're hitting like the 50% mark on all of that. And then we look at some of the gaps. There's clear gaps that peer support could fill if we use it in a better way. Next slide, please. So we really shouldn't be just saying, are you taking your meds? What's your PHQ-9 score? Have you seen a doctor since you were hospitalized? I mean, those may be important, and they are important, and so it's not that we discontinue gathering that information, but there's more to the story that we need to look at, far more, if we're going to really be effective in providing people with services that really change the quality of their life across the board. Next slide, please. If you look at those traditional measures, do they give you a clear sense of what's happening with a person? When a person is discharged from a crisis stay, they've come into a crisis unit. The average stay in crisis units now is anywhere from 3 to 5 days, sometimes as much as 7 or a little longer, but generally pretty short. And so the purpose of a crisis stay is stabilization. And hopefully the person comes down or comes out of the crisis situation is a little bit better able to think through what's going on for them and to make better decisions. But when they go back out of the hospital, they're going back to the life that they were in before they came in. So what should we be measuring? What do we currently measure in peer support? And what really matters to the people that we're serving? Next slide, please. So really the first question should be, what are the outcomes we expect if we add peer support to a program? So we've got existing programs, and over the last 25 to 30 years, as peer support has come into the system and grown, and it's getting quite prevalent now. It's not available everywhere, but it's moving in that direction. So we begin to introduce peer support into existing programs. We don't always know exactly what it is we want peer support to accomplish in that program. You know, I think a lot of provider agencies, everybody hears about peer support. It's talked about at every conference. There's papers written about it. We're starting to get meaningful research about it, though that's still really in its infancy stage. So when we set up a program, how do we decide what we expect to come out of the addition of peer support? And we need to look at that very carefully, because peer support is a game changer. It's not services as usual. So are the goals for peer support different than from the other things going on in the program? Excuse me. What specific skills do peer specialists need to accomplish those outcomes? And we can talk about that, because if you add peer support to a program like supportive housing, or you add peer support to a program like in a crisis unit, the skill sets that are required are very different. You know, there's some commonalities that we all go through when we go through peer support training, but then there's a lot of things that we learn through experience, and we learn some of it through our experience before we even get involved in peer support. And that's where peer support comes from. It's that lived experience that we kind of share with each other. But the skill sets for the different jobs that we're now introducing peer support into can be very different. And when we ask peers to do something, do they align with the core competencies and the scope of practice that are spelled out in their certification? Are we actually asking people to do things that they are qualified to do based upon the certification in their state or local area? Next slide, please. So we know that peer support does produce positive results in rehospitalization rates. It's one thing that really moves the needle on rehospitalization rates in almost every program where it's introduced. It lowers rehospitalization rates. It lowers emergency room or emergency department usage. It increases self-management. So when people begin to take ownership of their own treatment and make the decisions about their treatment in partnership with providers. And we also know that when we use quality of life measures, we can generally see that people rate their quality of life higher after they've begun to receive peer support. But what we're comparing these increases to or reductions to is treatment as usual. And treatment as usual is not a high standard. I mean, basically, we're looking at things that have been going on for many, many generations. And, you know, we can all see some progress in the behavioral health system. But we can also look at individuals, and that's where we need to be looking. When we look at the individual, is each individual doing better? Are we able to tap in to the wants and the needs and the goals and the ideas for the future of each person? And we're not. And we need to begin to shift our focus to that. We don't really know what the potential for peer support is because we haven't had good quality improvement measures. In other words, we weren't looking at the essential aspects of peer support and the kinds of results that it can get that are perhaps more subtle than looking at something like rehospitalization rates. Because when you begin to look at that, then you begin to see that peer support is far more flexible. You know, when we started doing peer support, you know, it kind of started in the 80s, but it really began to move into community mental health more solidly in the 90s, and then certification began around 2001. Since that time, you know, we've seen that peer support is growing. We know that there's far more people that are certified now than even just a few years ago, and we are the fastest growing workforce within behavioral health. And behavioral health is one of the fastest growing workforces. In fact, we have shortages of many professions. And as a consequence of that, in the beginning, when peer support was introduced into, say, a community mental health center, you might have had a peer support worker. Sometimes they called them, peer support counselors or any number of names, because we didn't have that peer specialist role, that certification role in the early times. But in the beginning, generally, we would introduce peers into like day programs. And so they might participate with people receiving services through some sort of day treatment type programs. And those type of programs were not terribly effective. The beginning of day treatment generally was something that was kind of copied out of developmental disabilities to give people something to do and trying to make it meaningful. But what happened was people would go into a day treatment program and they would stay in it for years and years. And consequently, they were just doing the same things over and over, and they were relatively minor things. And so the peer support person might help people kind of by showing them how to use public transportation, perhaps, or how to balance a checkbook, perhaps. I worked at a community mental health center where one of the activities of the day, a certain day of the week, was everybody made popcorn, and then they put it on a cart, and they took it around the community mental health center, and they sold it to the employees. And the peer support worker was just supposed to walk around with them, make sure everybody was okay. And that was the idea of what peer support was. Well, now as we look at that transition over 30 years, we're beginning to see peer support begins to move into the community, helping people as individuals, running support groups. We've introduced it into inpatient settings. We've introduced it into emergency rooms. We've introduced it into mobile crisis teams. We've introduced the concept of peer respite centers. We've introduced it into almost every area that we can think of, and we're just beginning to understand what its potential can really be. Quality improvement measures that we currently use in most programs aren't really geared to measure the proper things to show how we can continue to evolve and improve peer support. Next slide, please. So when you start a new program, you want to build quality improvement measures into that program. So you look at certain data points that you want to measure. When somebody comes into a program, you try to get some baseline information. For instance, you might want to know in the last year or the previous 2 years, how many times was a person hospitalized? How many times were they in crisis in an emergency room or had somebody go to meet with them in crisis? We might look at, how successful have they been in finding housing that work for them in the community. We look at involvement in certain kind of programs. We look at like rates of people showing up for their appointments and whether or not they are medication compliant. Well, these things, yeah, okay, I understand why we measure those. But those aren't that's not the data that we want to look at if we want to improve peer support. I mean, the main thing that I think we can all agree on is the main purpose is we want people's lives to get better. We know that any benefit from peer support is good. We know that dropping rehospitalization rates is good. We know that dropping ER rates is good. We know that satisfaction with services is good. We know that everything positive that peer support does is good and in its own way important. But how good could it possibly be if we begin to measure it in a way that really applies to what peer support's capable of? Next slide, please. So what should we measure? Well, the first step when you begin to introduce peer support into a type of service is to understand what are the required skills that are needed from program to program, because they vary. So for instance, if we wanted to look at a mobile crisis team that included a peer, and we wanted to look at people going into the community, meeting people in their homes or in other areas in the community, and doing that one-on-one type peer support that peer support is so good at, the skill sets there's some of them are we have in common. Obviously, we need to be able to communicate and listen. We need to be able to build trust, and we need to be transparent. But some of the other skills are somewhat different. For instance, when peer support's introduced into mobile crisis, you're going into a situation that can be quite volatile. And generally, crisis calls, they come in through 911 operators. If you're in an area that has CIT, Crisis Intervention Team training, where law enforcement's been trained in it, that's one step forward. When you have a mobile crisis team, then the law enforcement responding to the call will be accompanied by a mental health clinician that is able to make a determination if somebody can be taken in involuntarily for assessment. And that's generally a 72-hour hold to assess somebody and see where they are. And it's based primarily, the wording changes a little from state to state, but it's based on danger to self or others. So what is a peer, what's their role when they come into it? Well, they can play a lot of roles. One of the things they can do is they're there, they can build trust more quickly than other people because they're there to support the individual. They're not there to assess them. They're not there to arrest them. They're not there to handcuff them and put them in the back of a police car and drive them to a crisis unit. They're there to support the individual through that experience of a crisis call. So they're able to kind of translate what's going on. They can tell the individual, here's what's going to happen. So-and-so is going to come over and they're going to ask you questions. Law enforcement, if there's a mental health professional, is there for safety. They need not take any role as long as the situation is calm and safe. And so the peer is able to communicate on this other level that's based somewhat on trust because they can rather quickly go in and kind of let the person know, I've been through this kind of experience myself, and here's what we can expect to happen. But don't worry, if you have any questions, I'm here to answer them for you. So then the person may, the crisis may be resolved in many different ways. A person can end up going to a crisis unit. They can end up going to a shelter. They can end up being arrested if there was some sort of, criminal activity involved. They can have a loved one or a family member come and pick them up. There's all kinds of ways. One of the things that you look for, is this truly a mental health crisis? Is substance use involved? Do we need to get people to a place where they can address their substance use issues? So all of that can be resolved, but in a much calmer way once you introduce a peer supporter into that situation. And for those of us who have gone through these kind of crisis interventions, generally by law enforcement, we know it can be quite traumatizing. You're already in a state of crisis. Your life is just spinning around you. What's going on is not always completely clear to you. And frequently, in many communities, the only people that show up are law enforcement officers. And what do law enforcement officers do? They take control of a situation through the skills that they learn. They use a command voice. They use a command presence. They're there in their uniform. They've got that belt with weapons. They've got handcuffs, And they tend to try and control a situation by speaking very loudly and very authoritatively. Well, people, when they're in crisis, don't necessarily respond to that in a positive way. And so consequently, you may see that it will actually escalate in those situations instead of calm down. So when a peer support person is involved, or even when a mental health professional is involved, there's at least a buffer between those two parts of the situation. So what we need to do is we need to measure things that depends on the goals of the particular support we're trying to provide. If we're providing one-to-one support in the community, it means we go and we meet with a person where they choose to meet. We talk about what's going on in their life. We talk about their goals. They talk about the way they're going to address their goals. We help them to locate resources in the community. We have all kinds of tools at our disposal, and we still use those core peer support values to keep the conversation flowing, to be in a way that the person feels safe and protected. And So, we're trying to achieve the same things, but it's completely different situations. So when you're measuring the effectiveness of peer support in a mobile crisis team, it's going to look different than when you're measuring its effectiveness in a one-to-one community-based meeting. Also, individuals' needs, even in the same program, are often vary from other people. So somebody in that one-to-one community-based kind of meeting, one person may be very high need. They don't have a place to live. They need connection to housing resources. They may not even be on benefits yet. They need to somehow connect to a way to get onto SSI or SSDI if they're qualified for it. They may need to find a shelter. They may need food. They may need to connect to services. They might want to find a peer-run recovery center or someplace that they can go where they feel safe and supported. The needs vary from person to person. And so we've got to look at each aspect of that and be able to understand, is the peer support succeeding in each of those things? What we do is different from person to person. Therefore, what we measure can differ from person to person. Otherwise, how do we really know that what we're doing is effective? We know one thing. We know that the overarching goal of peer support is to make people's lives better. Next slide, please. So peer specialists understand, like I said, the object is to make people's lives better. And the question is, what's the best way to do that? Much of peer support is about being able to act in the moment with the individual, to be there, to be in that moment, to hear what the other person says, to respond in the appropriate way, which may just be listening, or it might be kind of an encouraging way for the person to feel that it's safe for them to talk to you. It might be to provide them with some tools in the community that they might need. Again, as I said, we have to be there in the moment and deal with the situation facing us instead of coming into each situation with a set of tools that are identical situation to situation. We can't do a program in a box in peer support. We can't say, okay, here's exactly what you do, and here's the results you can expect, and here's how we measure it. Peer support doesn't work that way. Peer support is person to person. The evolving practice of peer support can be so much more than it is right now if we can just begin to really look at what the effects of it are and where we can improve it and where we can build on the success that we've had so far. So now I think I want to turn it over to Kelly Davis. And Kelly?
Awesome. Thanks, Patrick. Next slide, please. So I just want to restate the importance of this issue of measurement and peer support, because there's a saying, right, what gets measured gets treasured. And what we measure in terms of the impact of peer support can impact the investment in peer certification and peer training programs. It can impact where we're paying for peer services and if we are and how often we are. And it can also really impact reimbursement for peer support specialists as providers, which is, as everybody in the field knows, a serious issue, especially depending on where you are in the country and what kind of service or what setting you're in. And it's pretty evident that the way that Patrick talked about quality measurement before has really driven where peer support is and the state of where it is right now. So when you think about peer support as a cost savings, a lot of times peer support programs are used specifically focused on folks who have a history of a lot of hospitalizations or emergency department usage. And the idea that that's what's important and that's where money should go, and that's what we're tracking, shapes further investment there, right? And that logic has spread. So it's not just reducing people from being re-hospitalized in an inpatient psychiatric unit, but now we're seeing failures on the other HEDIS measurements. So we're seeing issues with Are people taking medication or engaging in services as provided? Are people actually connecting to resources after they're in the emergency department, after they leave the inpatient psychiatric unit? And the strength of the peer support community is not, oh, we get people, certainly not we tell people to take their medicine, certainly not we tell people what they should do for their care, but it's the nuanced understanding of that data based on lived experience, right? So if I see that somebody is not taking their medication, I don't think necessarily that that's good or bad. I think, okay, you know, let's talk about why that is what you want to do. And the research shows that people who receive peer support services are better supported in making the decisions that they want about their health care. And it's not about, you know, do you do this or do you not? It's about figuring out what you want. The same thing with the connecting with folks after hospitalization and different points like that. And I think peer support has been effective because we understand that nuance. But as we want to expand the workforce beyond where it's been, beyond public mental health, beyond psychiatric hospitals and emergency departments, we want to make sure that we're focused on not just we know the nuance and we know how to improve what other people think are important, but we're measuring the things that we know are important in the community and to the people who we support. Next slide, please. So these lists of different measures are just different ways conceptually or measurement-wise that you can look at things. So all different perspectives that you can use in your programs. Many of them are really certainly philosophically aligned with the values of the peer support movement and the broader things that peers understand about what matters to people and how people live their lives. So the first would be person outcome measures. So person outcome measures are originally came out of developmental disability community, and this is a type of measure where you can do training and it is interview based. So you're taking a baseline, right, and then over time conducting the interview again. And we're not measuring just traditional, are you using services and are those services moving your clinical scales, but things that are really important to people, right? So are they safe? It's really hard to feel good when your rights aren't being respected, right? When you're being abused, that is a critical thing to address if you're really going to talk about improving mental health. Do you have social support and relationships, social support? And Emily, who's hosting, and Patrick, if you joined the last webinar, they're doing a lot of work on the importance of social support, but the research shows that isolation and loneliness can have worse health outcomes over time than smoking. So social relationships aren't just something that people find important, they're actually really important to people's mental health and physical health. People want to be part of a community. They want to make decisions about their own well-being, so not or their lives or where they work or what they do. So not just a passive recipient of services, but activating people and making sure that they feel empowered to do whatever it is that they care about. And the same thing with goals. So people are choosing what's important to them, and they're realizing what's important to them. And that's really supported through the relationship with the peer specialist. Next slide, please. And that kind of goes to this combination of goal setting and also in the context of social determinants of health. So social determinants of health is a very popular concept that we hear all the time. It's really hard to be well when your basic needs aren't met. So whether, you know, it's hard to make your follow-up 7-day appointment, make your follow-up 30-day appointment if you don't have access to transportation. If you feel extremely isolated, or if you don't feel safe, or if you don't have food, your well-being is certainly tied to that. So this chart in particular came from a pilot program that MHA did with our affiliate in Northern California and Kaiser Permanente. In the pilot, they had 2 peer specialists working full-time, and the folks in the program were people who were Medicare and Medicaid eligible, and they were receiving outpatient services with a mental health diagnosis and at least one other physical health diagnosis. And through the time that they were in the program, they worked with the peer specialists to, as you can see, pick the topics and areas that were important to them and work specifically towards those goals. So whether it was a goal in improving their mental health, a goal in figuring out transportation, or issues with pain or taking care of themselves or substance abuse. And through this lens, combining the peer support and the power of the peer support relationship and storytelling and connecting with people, this goal setting and activation towards all of these broader things that seriously impact people's health and well-being. Over the course of the year with 2 full-time peer specialists, saved them over $1 million. So it's not just things that we think are important, but these things really do significantly impact people's lives in the measures that the system typically looks at, but also in the measures that we see are really important to people. Next slide. So this is a really exciting, different framework that we've talked a lot about at MHA. So this model that you see on the slide is known as the it falls under Flourishing in the field of positive psychology, but it is known as the dual continuum. So positive psychology as a field is largely attributed to Martin Seligman, but developed as a result of a lot of leaders in the field of psychology who saw that psychology was really deficit focused, and it wasn't necessarily focusing on the things that make life worth living, the things that are exciting or engaging or positive or happy for people. It's really the study of well-being. And the dual continuum kind of helps to explain some of the things that you figure out as a person with lived experience and with a diagnosis when you're getting support. Because in my experience with positive psychology and with this work in the field, there's kind of this thing where there's people who can have positive mental health, and then there's addressing people who have mental illnesses. And the dual continuum really provides a way to look at people are on either ends and anywhere in between those spectrums, and they are not separate. They're not separate. So in my experience, I can be real high on the PHQ-9, but actually have a really strong sense of flourishing. And it's a really cool model that kind of tackles some of the traditional assumptions that, for somebody who has a disability, a psychiatric disability, my major focus is not necessarily reducing my score on a clinical scale. It's these other things, and it's not, when you talk about the disability rights community and Mad Pride and folks who say, this is just who I am, this is a part of who I am, this is a way to kind of conceptualize how you can support well-being even when you're not struggling with a mental illness. Because, for example, there's plenty of people who do not screen positive on any clinical scales who are really having a hard time. So it's a different way to examine that. And it has also measurement scales. So you can see here some of the different things that they measure. So emotional well-being, similar to person outcome measures, but also looking at psychological well-being. So how do you accept yourself, your relationships with others, personal growth, purpose in life, your sense of mastery and autonomy, or we know self-direction and self-efficacy are incredibly important for anybody, but particularly in recovery from mental health challenges. And social well-being, so social acceptance, integration, contribution, coherence, and growth. So this Flourishing framework is really interesting, and it comes from a man named Corey Keyes, who is a researcher at Emory University, because it really measures a lot of and accounts for a lot of the topics that the peer support movement has, realized, but also focuses on teaching and activating in other people. And it allows the recovery or well-being or, consumer movement and values to stand and fit within and alongside a kind of more medical model understanding of psychiatric conditions and diagnoses. So just a really interesting way for us to say, okay, yes, mental clinical scales are clinical scales, but these are the other things that are incredibly important, and they might actually be more important sustainably, but also in terms of how somebody wants to spend their time and take care of themselves to measure. Next slide, please. And the last bit that we'll go through in terms of a different way to measure or look at things, they're known as the PROMIS Measures. So they are the Patient-Reported Outcome Measurement Information System. And they are rigorously researched and were developed by NIH, National Institute of Health. And they are reliable and precise measures, and they focus on physical, mental, and social well-being. So this is another way to take kind of a clinical approach, but looking at more broadly the different things that are important to people in different ways that can impact health and well-being, and that should be considered in the provision of all health services, in particular mental health services, but really for everybody. And we'll go over some of those. So next slide, please. So here's some of the things. And I know when I first saw and found out about the PROMIS Measures, I was so floored by just this approach, because it really reflected the things that I see as being extremely powerful for people in their recovery and in their growth and in their understanding of themselves. So meaning and purpose. So I have a reason for living. I can make sense of my existence. I understand my life's meaning, and I have lots of reasons for living. So really important, especially, when things come up and when you're having challenges, having a sense of a broader meaning and connection to something bigger than yourselves and a reason to move forward can be incredibly powerful. And having that as a focus on what we're building or what we're trying to grow or support in somebody can really help kind of keep people moving forward, even in struggle. Next slide, please. General life satisfaction. So I'm satisfied with my life. I have a good life. I have the things I want. Patrick kind of mentioned earlier, we just want people to feel good, right? Life satisfaction and quality of life are incredibly important, and these are just, seem really simple, but are really important to people. Next slide. Appeal of substance use. I also think that this one, as a person in recovery myself, I think that this is also incredibly important and something that you kind of learn oftentimes as an individual go through your recovery, is that, it's not necessarily did you use substances or did you not use substances that provides a complete, understanding of somebody's well-being, but also what they're feeling inside. So I use drugs to make it easier to talk to people, or because I like myself better, or to relax. Measuring things in this way and conceptualizing things in this way and understanding them like this, as opposed to just looking at abstinence versus not abstinence, use versus not using, can really help people better understand themselves, but can help us be more specific in trying to figure out, what are the areas that are important to people that they feel makes them want to use substances when they do not want to use substances, or when they would not necessarily be beneficial to them. Next slide, please. and social isolation. So I mentioned earlier, there's just an incredible amount of research coming out right now about the serious short and long-term impact of social isolation. And we're seeing not just mental health condition specific, among older adults, among young people, millennials, and Gen Z in particular, really devastating rates of people reporting loneliness or feeling isolated or separate from other people. So I think social isolation too, in what we understand about its impact on your psychological and emotional well-being, but also your physical well-being, right? Our brains, we're social creatures, and our brains are wired to want to connect with other people. Approaching it from this way and measuring it in this way can help us build and target this thing that's incredibly important to people. So asking if people feel no longer close to anyone, or if people don't understand them, or they feel alone even when they're not alone, right, is much more specific of a question than what you would typically get asked in a questionnaire and what you would target when you're working with somebody. So it just allows us to be more specific in what matters to people. In this area in particular that we're seeing, you know, they say like loneliness is the new smoking. We're seeing just really devastating impacts here. So I think too, it provides kind of peer support as a profession, as a field that has been focused on connection and making people feel less alone and helping support people socially. I think peers and the peer support movement is really poised to really help address some of these broader issues as well. Next slide, please. Emotional support. So I have someone to talk to who will listen to me. I love and affection. I have someone to talk to when I have a bad day. I've been thinking about this a lot recently. You know, we have all of these mental health campaigns that say reach out and talk to somebody if you're struggling, and it's really amazing to have things like crisis text line where people can text somebody for support, or a suicide prevention hotline where people, or the Trevor Project hotline where people can call somebody when they're in crisis or distress, or warm lines. But it's also, you know, important too to have someone in your life who you can talk to when you have a bad day. And it's, you know, again, something that's understated and wouldn't necessarily be what was focused on in somebody's well-being and what we would target in mental health services. Next slide. So the future. And what does all this mean? So I think I got at this a little bit earlier when I talked about what gets measured gets treasured, right? So not just how do we invest in the workforce, what do we pay for, and how do we reimburse? So healthcare financing has been on this pathway towards really shifting toward value-based payment. So that means that the services that we invest in, but also how much we pay for services and what we pay for services are really dependent upon their ability to demonstrate their impact. So it would typically be on reduction of PHQ-9 score, of follow-up after hospitalization, making sure that people don't have repeated cycles of inpatient psychiatric hospitalization, which are all great. But as we're moving towards this system, we really want to make sure that we and the values of the peer support movement are involved in saying, you know, in a conversation about what is value and what is valuable to us and what is valuable to behavioral health. And I think we're in a really great position because there is an increased influence on whole health and well-being in broader healthcare. So, you know, these are things that have been ideas in the peer support community, but even the kind of high rates of comorbid health conditions, right? For a number of different reasons, including medication side effects, right? The high rates of diabetes and psychiatric diagnoses. Healthcare more broadly is figuring out, oh, you know, we don't want to just focus on mitigating risk or bad things. And I think that also brings a really interesting question up as well, because peers are expanding into new settings. So primary care, in particular, integrated behavioral health, those are settings where peers haven't necessarily been before, predominantly been in community mental health centers and peer-run organizations and those kinds of things. But there will be really, this creates a really interesting question for this upstream movement or this before stage 4 movement, because peer support in terms of how it's valued has traditionally been for folks who have been failed by services in very serious ways for very extended periods of time. And if we're moving upstream, right, we have the before stage 4 logo at the bottom of the slide. That's kind of MHA's slogan around we shouldn't wait until crisis before we support people. But what that means is that makes it especially important, because if we're providing peer support upstream to somebody who might not have a high history of going to the hospital or going to an emergency department, we're going to have to advocate in a number of different ways to demonstrate the value of peer services. And I think that having these conversations and looking at these different frameworks are a really important part of that conversation. I think peer support has had a very ongoing but important impact on culture, and having these conversations and emphasizing the importance of different types of measurement in peer support, but in mental health more broadly, can have a significant impact on the culture of organizations that provide services, particularly other folks in the field who provide services. I think it will also be incredibly important in terms of training, making sure that, again, other people and peers themselves have access to this information and have an understanding of it. And I think, too, what's really exciting about the future and about this is there are an increasing number of people who, people with lived experience have always done lots of wonderful things, but there's an increasing number of people with lived experience who openly talk about their lived experience, in addition to there being an increasing number of people with peer support backgrounds and who have worked as peer specialists who are in leadership positions throughout healthcare. So I think that having bigger seats at bigger tables and coming in with these ideas about what is important to people receiving services, and what we've found through the peer support movement to be, okay, yes, here's the things that you measure, but the underlying nuance is the things that we're measuring and that we care about. And then having that leadership and having those conversations in rooms with more and more people can really help us lead and continue to shift, where we're focused from an inclusion of kind of the traditional measurements, but really towards the things that build up and impact people's day-to-day lives and overall well-being and quality of life. Next slide. And Patrick, did you want to go over this one?
Sure, and I have a few comments about, I think I'm hearing an echo of the things that Kelly was just talking about. I mean, for years we have, in the peer support communities, we've all tried to figure out how can we help people at an earlier stage, like Kelly was saying, before crisis, before stage 4. How do we help people based around social determinants? And I think that the movement towards positive psychology, which allows for the fact that a person can both have a diagnosis and have a high quality of life, is part of that answer. We're starting to see that we can actually move the needle by providing people with the positive tools they need younger and younger, so that they never have to reach that crisis state. Doesn't mean that maybe they don't have a diagnosis, doesn't mean that they have no symptoms, but that their life is of much higher quality. And, you know, when we, many of us who've worked in peer support for a long time, you know, we look at the people our own age and we look at the people that we've served around, and many of our fellows have been in the system for a long, long time, and they've never found a way to break out of the system. It's just kind of a revolving door, living with symptoms, you know, trying medications, maybe finding some that work, maybe deciding that that's not the way to go for you, multiple hospitalizations and crises in our lives, and so we become sidelined in society. And I think if we start to really take this positive attitude and that peer support is more prevalent throughout the lifespan, then I think we're going to see a lot more changes. One of the things that we've been talking about and looking at is that the skills for peer support are kind of universal. We know that peer support exists in other healthcare states. I mean, there are people who work in peer support for diabetes, for cancer of different kinds, for heart disease, for, you know, COPD and asthma. Peer support exists, but right now, the only place where it exists, where it's fairly highly organized, is in behavioral health. And if you look at the people in behavioral health who have gotten involved in peer support and perhaps have their certification, or they're working in a state like California that doesn't have a certification, but certainly has well-trained workforce, we also see among those people all these other types of health problems. You know, we do have a very high rate of obesity. Consequently, we have a high rate of diabetes and heart disease and you know, breathing disorders. And we also, you know that there are neurological effects because of sometimes long-term usage of some of the medications that maybe help us over here, but then years down the road we start to see things like tardive dyskinesia and other kinds of ramifications that we didn't expect. So we've actually got a workforce that can work across these boundaries and work into other areas. Those PROMIS measures that Kelly talked about are really starting to get to what I was talking about looking at the details of what peer support is doing and can do. And that's, as we begin to measure things on that more personalized level and really get down to when I talk to this person. And, you know, a good example that I've talked about many times, when somebody has been hospitalized a lot, or they've been in intensive services for many years of their life, when you talk to them about goals, what are your goals? And frequently their goals are to stay out of the hospital, to stay out of jail, to stay on their medication. And they don't believe that they can have greater goals than that because their life has been in chaos for so long. Well, one of the best parts of doing peer support is helping people get to the point where they can actually look out at the horizon of their life and understand that they can have all kinds of goals. They can have a life of their own choosing. And we're finding different ways to get to that point. And, you know, so I think as peer support matures, our understanding of its potential matures, and each time we push it another little step forward, we see it can go even further than that. We begin to see the subtleties. We also begin to see the macro vision of the fact that it can work across healthcare and still have those same effects. So as we begin to look at it under this new light, and as provider agencies begin to, you know, increasingly add peer support into existing services or new services that they are starting up, and they start, as I say, to add peer support to it, then we can begin to build into those programs ways to make sure that we're looking at the right things, that we're measuring the right things. And if we can do that, it allows us to know if we're doing the right thing. And when we see that something is not working, then we can change it before it goes on and on and on and on. And that's what quality improvement is about. And so while it's it sounds very clinical, sounds like it's part of the system and all of that, quality improvement is what anybody wants in their life. If they do anything, they want to do better. We say we learn by thinking about something, then we do it, then we analyze the ramifications of what we've done, we think about it some more, and we do it again and do it a little bit differently to get a better effect. And that's what quality improvement is in peer support. So we are at this tipping point. We're at a place where peer support it's already exploding, but it's going to explode even massively more. Peer support needs to be available to everybody, no matter how your healthcare services are paid for. We need to find ways to make it available to everyone across the healthcare spectrum. And then we can begin to really change the trajectory of people's lives. They won't have that type of life where they spend a large part of their life either in a hospital or alone or feeling pushed away by society. They become members of the community. They pick out their own goals, and they have the life they want. So thank you very much for joining us on this today. And we want to see if you have any questions. And I think Emily is going to set that up through the comments board.
Yeah, thank you guys. We don't have any questions right now, but as I mentioned earlier, that chat bubble in the gray start meeting box, anyone can type in there and we'll hang around for a little bit to see if anyone has anything they want to chat about. Okay, we've got one, how to access the PROMIS measures.
Actually, if you just Google PROMIS, all caps, it'll come up. And there's a couple of websites that have the entire measure available for free. It's not something you have to pay for. There's good explanations about how you evaluate the outcomes for it. And so it is something that's readily available. Kelly, did you have a comment about that?
Yeah, so they're through the NIH, but there's also a website called healthmeasures.net that has a lot of different things. There are so many, there are so many PROMIS measures. So it's really interesting to go through and look at all of the different things that they have available too. But they're all available online.
Anything else, Emily?
That's it so far.
Well, I think, when you get into a new subject like this, it's not unusual for people to need to think about it before they're able to really figure out what they might ask. And so, Kelly and I are available through Mental Health America at almost any time, and you can go on the mhanational.org site where you can go directly to our peer services. So, did you put up another slide?
There you go. That's what I just wanted to see. That's what our email. Actually, those are old. It's just mhanational.org now. But those work. It looks like we have.
Anyway.
Oh, go ahead.
Go ahead. We have another one?
Yeah.
Yeah. Does peer support use telehealth or just in person?
No, actually, peer support is moving into telehealth. There's a private company in Houston. I think it's called TeleMD, but I could be wrong about that name. But anyway, they're using peer support in telehealth quite a bit. There's a number of websites around, and it can be done in different ways. A lot of them come and go, but it is a growing need. And it really is important that we figure out how to do it well, because we've got so many people in this country who don't have direct access. They don't live in a place where peer support is readily available. They may live in a rural community, or they may live in one of the western states where you can drive 200 miles before you get to the next mental health center. So you know, telehealth is really important. All of these new kinds of healthcare tools that are coming available are exciting. You need to look at them very carefully before you buy into one. But you know, it's definitely got its time.
Yeah, there's a lot of like video chatting and phone calls and different folks doing kind of online or virtual or telephone-based peer support. It's also, I mentioned earlier, public mental health is, or public behavioral health is really, you know, Medicaid is really, and state funds are really where most of peer support is paid for. The majority of the growth that I've seen as peer support is starting to expand to commercial insurance and the private sector has been telephone-based peer support, particularly for opioid use disorder. So the largest commercial insurer in the state of New Jersey, for example, now pays for telephone-based peer support for people diagnosed with opioid use disorder. So that's a huge area of growth right now, but I think also for the future and the expansion of the field.
It looks like people are starting to hop off, so we can end here for now. But we can go back to that slide with Patrick and Kelly's emails. I'll also be following up this week with the full recording and the slides, and you're welcome to reply to me, and I can forward your questions on. But thanks for coming, everyone. Have a good day.
Thank you, everyone.
Thank you.